Now I invite Dr. MARIAN. She needs no introduction. She's a senior consultant, oculoplasty in Giridhar Eye Hospital. Madam will be talking on failed DCR and what next.
Hi, good morning. Thank Dr. Anne for the opportunity. So, I'm going to speak about the failed DCR. In fact, managing failed DCR is actually a pain. And if it is your own DCR, then it's another problem, okay? So now, so in this, you can get an early failure or late failure. Early failure is usually within 1 week. That is something probably can be related to your surgery, or can be late failure because of the patient's problem, like scarring, etc. And you have to differentiate between anatomical failure and functional failure. So anatomical failure means it is passage is blocked. Functional means passage is free, but patient is still symptomatic. So first we have to analyze the causes of failure. So most common is fibrous tissue growth. Then second is inappropriate ostium in terms of size as well as the position. Then the inadequate osteotomy. Sometimes the bone removal is failed to expose the sac completely, including the fundus and the proximal NLD. So we have seen the DCR from Dr. Donna. Then associated common canalicular block and inadequate sac opening. There's some nasal causes we have to be careful. Nasal polyp. So this shows the importance of nasal endoscopic examination. Intervening ethmoids, that is one of the very common thing which we come across. So in 1996 in the journal, in 46% of cases they have come across ethmoids in between. So if you come across ethmoid, you have to do a partial ethmoidectomy, otherwise they can block the ostium. Then you can get synechia in and around the ostium, then internal ostium stenosis. And another most common is granulation tissue. That again depends on multiple factors. In spite of good surgery, sometimes the patient's body itself shows some reaction. Then associated deviated nervous septum and failure to address Congo bullosa, that is anatomical variant of ethmoid where pneumatization extends to the middle turbinate. See in this you can see that Congo bullosa. Rare causes, here some masquerades basically, occult carcinoma or ethmoid sinus osteoma, or soft tissue obstruction due to inflammatory diseases, sarcoid, vaginous, fungal infections. So in this you can see patient already undergone DCR. You can see the ostium is there, but lots of soft tissues covering the ostium. And look at the sinus. She had fungal sinusitis. So this was a case of fungal granuloma. So coming to the clinical assessment. So clinical assessment is more or less the same as the approach to watering. And when you say failed DCR, rule out all the other causes, blepharitis, trichiasis, entropion, then systemic inflammatory diseases, facial palsy, like very trivial facial palsy, nocturnal lag of the almost. These are the some things which we miss when a patient presents with watering again after DCR, because sometimes DCR can induce a transient paralysis of the orbicular iris, but it will recover later. Coming to the clinical assessment, again test for lacrimal patency, which we have already learned from the first talk from Dr. Indu. Dye disappearance test, lacrimal irrigation, probing. So probing is very, very important because we have to differentiate between the hard stop and the soft stop. Sometimes after DCR, we can get an associated common canalicular block, which can be differentiated with probing. Then comes the importance of nasal endoscopy. You have to do sometimes CT scan orbit with the paranasal sinuses to rule out sinus pathology. Diachrocystography can be done especially to delineate the lacrimal drainage tract, exact site and nature of obstruction. Scintilography, I usually don't do. Then first we have to identify some high-risk factors. So during surgery itself, if we are the primary surgeon, if the small sac opening, always keep in mind this can close. Then prolonged surgery induces lots of inflammation, again fibrosis. Then when you're doing surgery in the active phase, again another cause, the inadequate flaps. During the surgery, your flaps has been partially cut off or something has been happened. Then intraoperative fat prolapse, that is the lateral wall of the sac, injury to the lateral wall of the lacrimal sac can cause the fat to prolapse into the ostium, which can later lead to failure. So if you see fat, always excise and do a cautery. Then finally thermal damage using too much of cautery. So how to manage this? There was a meta-analysis published in Orbit 2023. So what they have concluded is whatever method we are comfortable, either if you're endoscopically you can revise, if you're comfortable, or externally you can revise. So the type of surgery doesn't matter in revision DCRs. So coming to the management, we have to revise the DCR, either external or endoscopic approach. So in case of external DCR, you can go to the same skin incision, need not give another scar to the patient. Cut anterior limb of medial canthal tendon. I usually don't cut in the primary surgery, but in the revision surgeries, I always cut the anterior limb of MCT, medial canthal tendon. Then identify the edges of the original rhinostomy, see how, where exactly is the problem, and then free the periosteum all around for at least 4 millimeters. See this, this is when you are putting the probe, there should be a minimum size of around 4 millimeter all around the ostium. Then osteotomy has to be enlarged to expose the virgin nasal mucosa, because already the existing nasal mucosa might have been and examine the ostium carefully. So always remember, keep the flap under tension. Otherwise, if the patient scars, the flap will go down and it will occlude the ostium. So then few adjunctive measures can be used. We can use mitomycin C. I actually, in the primary DCR itself, I use mitomycin C in all the cases. But in revision DCRs, you can give circumostial injection. Then silicone intubation is little controversial because there was lots of studies, silicone induces inflammation. So silicone intubation also can be done because silicone sometimes induces granulation and leading to cicatrization again. Then if there is an associated common canalicular block, you can use Sisler trephine and to trephine the fibrous tissue and put an intube. Balloon dacryoplasty especially is used in internal ostium stenosis. To conclude, meticulous preoperative assessment is very, very important to identify the high-risk cases for failure. 3 most common causes, that is inadequate ostium, inappropriate sac opening, and cicatricial closure. Nasal endoscopy is a must. Decision regarding the revision based on your clinical evaluation, and most of the time you will land up in excellent outcome, but careful surgery is a must in such revision DCRs. Thank you.
Thank you, Marian ma'am, for that